Thereforcare is brought to you by CareScout with the goal of sharing real-life conversations about aging care. Views expressed on this program are the speaker's own. We don't provide medical, legal, tax, financial, or other professional advice. Always talk to your own professional advisors for advice tailored to your needs. Today's guest is Rein, Director of Provider Operations at CareScout.
1 in 4 older adults report falling every year, and those are just the falls that are reported.
Usually falls occur for a multitude of reasons. People are living longer. Folks are being sent home sicker and quicker from the hospital. Medications are added to their daily intake. Some of those medications have some adverse side effects. All of those things can contribute to a fall.
Why is falling so particularly bad for older adults?
Unfortunately, hitting their head, or one of the most common is they could end up fracturing a hip.
It seems like a common theme for these conversations is how important it is to have a very honest and open dialogue so that you can stay as safe as you can, as long as you can in your home.
When someone is afraid of falling, you start to see their body mechanics change. If you have the urge to stand closer to them or feel like you're going to have to play catch, that's a big one. The biggest thing is if you see something, say something. Don't ignore it, because if you do, it'll only make it worse.
Hi, welcome to the Thereforcare podcast by CareScout, a podcast about all things aging care, whether it's for yourself or for those you love. This is Amy Rein, and today we are talking fall prevention. We've got with us Brian Kelly, a doctor of physical therapy. He's been both a clinician and operator in the older adult post-acute space for the past 20 years. And his focus has always been on making sure care consumers remain the focus of care delivery and that they receive the highest quality services possible. So welcome, Brian. Thanks for joining us.
Well, thank you for having me.
I want to start out today's discussion talking about the dangers of falls for older adults with a few what I felt were very alarming statistics about falls. So per the CDC, over 1 million or 1 in 4 older adults, and that's talking about people that are 65 years or older, report falling every year. And those are just the falls that are reported. Many of them we know go unreported or unwitnessed. And the age-adjusted fall death rate increased by 41% between 2012 and 2021. Both pretty alarming. But before we get into the drivers and what we can do to alleviate some of those potential issues that cause falls, I want to level set. When we talk about a fall, what are we talking about?
Well, quite simply put, a fall is any uncontrolled change in level, typically resulting being lower, not higher. And so that's the very simple definition of what a fall is.
Yeah, so it's not a stumble or anything you can't catch yourself.
Yeah, you actually have to change level and typically end up either uncontrolled back into a chair, which is very common, or unfortunately on the ground.
So why is falling so particularly bad for older adults?
Well, I think the resultant injury is obviously number one. A lot of folks, after sustaining a fall, do sustain blunt force trauma that's associated with the fall. Could be anything from, unfortunately, hitting their head, which could be obviously detrimental, end up in a TBI or a traumatic brain injury, or one of the most common is they could end up, fracturing a hip, which unfortunately lands them in a less than desirable situation, usually at the hospital, obviously, for some period of time, and then obviously some subsequent rehab work after that.
All right. So why are we seeing that huge uptick in the frequency of falls in the population?
Yeah, that's a great question. I think there's a few factors that play into that. I think one of them, people are living longer, right? And I think the other big one is folks are being sent home sicker and quicker from the hospital. Unfortunately, it's just the way that it is. And so that's probably the two main reasons. Usually falls occur for a multitude of reasons. It's not usually just one simple thing. And that can be, medication. Polypharmacy is a big one, right? As folks are aging in place for longer or living longer, medications are added to their, shall we say, daily intake. And so some of those medications have some adverse side effects, either by themselves or when they're combined with other meds, not limited to lightheadedness, dizziness, drowsiness. All of those things can contribute to a fall. You also got the just normal age-related changes. Unfortunately, that is kind of the shtick. What happens, right? After age 60, you start to see some decline in muscle mass and some resultant weakness. You also have some sometimes visual deficits that are kind of worsening over the years, and just a general balance decline, overall, whether it be they're not lifting their foot as high or their walking pattern has changed. That's a very common one, because it's kind of that fear of that open space. They don't want to kind of go outside of their base of support because they're afraid of falling. I think the other biggest one that I'd be remiss in not mentioning is a previous fall. That is one of the most common, unfortunately, warning signs that someone is going to fall again is if they've had a fall in the past. So all of those kind of contributing, not, P.S. and by the way, not also overlooking the importance of the actual physical structure where they live, their home. If the environment isn't well set up or suited for someone who's having some of these deficits, and they don't have the assistive devices in place. So I think there's a multitude of things that are contributory when it comes to falls, and that's probably from a overview, that's probably the bulk of them.
Yeah. So you went through several of those sort of physical changes that happen as we age that contribute to the higher risk of falling. Are there more sort of structural issues that we're seeing in modern house design, or, just the spaces that we're in each day that also contribute?
Yeah, stairs. Stairs, unfortunately, and very much so, not so much the ones that have a railing, but those without a rail. Very common for a while to see that sunken living room situation. I can speak from personal experience. My stepfather, when he moved in to the home that he's in now, it had a sunken living room. I was not there for that visit prior to purchase. Otherwise, I would have mentioned that possibly we would want to look beyond. And then his next step after moving in, no pun intended, was to remove the railing for those stairs. So I think that's part of it. I think the other thing that you do see the longer that someone lives in a home is just the natural decline of the home. I think, from a loose banister, I know when I used to show up for home care visits at patients' houses, that was always one of my first tests, right? I want to, how are they going to, when they egress the home, what are they going to be holding on to? If the mortar is loose, I know they're set up. So some things like that, I think, and then to the more technical side of things, grab bars in the bathroom, lighting, even something as simple as lighting is really something that I found, in my experience going into people's homes. It was amazing to me how often that there was a low lighting situation, which is inevitably going to set someone up for, possibility of falls. Because again, if your vision is declining and I'm dimming the lights, not a great and healthy combo. So between those two things, I think that that's really some of the structural things. And, obviously everyone seems to have their favorite throw rug, which they've got placed around the house. So even as many times as I, have asked them to remove that, I'll even remove it myself. And magically, when I came back for the next visit, it was back where it was. They didn't do the exercises I left, but they were able to actually put that rug back in place. So, but again, that's their home. That's why they want to stay there. It's their place. It's, everything's just so typically. So,
thank you. So when you are getting older and maybe it's you or your spouse, or you're looking at your parents when you're home for the holidays or things like that, what are some of those signs to look for that someone's fall risk might be increasing?
Sure. I think the first one that comes to mind is just basic instability. I think most of us can look at someone and say, if you have the urge to stand closer to them or feel like you're going to have to play catch, that's a big one, right? So I think that's one. However, many folks are used to guarding and kind of throwing people off the trail on that one. So they've kind of gotten good at that. And I think one of the things that I typically saw, which I don't know, this is not a technical industry term, but furniture walking was one of the biggest things. And you would see folks traverse from one side of the home, basically making good use of every piece of furniture, cabinet, sometimes wall, door threshold to make it across. Some it's because they were denying the need for an assisted device, a cane or a walker. Some it's because those items, while they use them outside of the home, they don't function well and play well kind of with the doorway width or whatever the case may be. So I think you do see some of that as some of the signs. And I think, again, a fall is one of the biggest ones. If you know that mom or dad has had a fall, or if I know that I've had a fall, I know that I'm going to be predisposed to have another fall. And this is truly a fall. This is not tripping over the dog. This is not, this is really, I literally lost control and was unable to catch myself. So, I think those are probably some of the major signs that you someone as a a layman would be able to pick up on.
Mm-hmm.
The other one that I should probably also mention, last one, I promise, because it get me going on this therapy tangent here, is the fact that when someone is afraid of falling, you start to see their body mechanics change. You start to see their legs make a wider base of support. You start to see the forward flexion of their trunk, right? They're leaning forward because they're scared. Well, if you think about the way that a building is built, it's built straight up, right? And people who are comfortable and feel structurally sound are straight up and tall. Those that are not, hunch forward. You wouldn't see a building like this. It's actually putting them at a greater risk for fall to move like that.
Yeah. So seems like we have sort of a lot against us in what's increasing the chances of people falling these days. What are some of the things that we can do to prevent falls?
That's a great question. And I've been struggling with this for 20 years, or actually enjoying being able to help folks with this for 20 years is what I should say. Maybe it's a struggle and help. But I think the biggest thing is, if you see something, say something. If there is something that you can see, don't ignore it. Because if you do, it'll only make it worse if a fall does happen. If you could prevent it because you saw some instability, try and convince mom or dad or whoever it may be that, hey, let's have you take a look at you. Have a physical therapist kind of just give you a brief once over. What's the worst they can say? No, you're doing great. You don't need me. And I have said that to folks before. That's the nice thing about being able to go out and see someone. I can do an independent evaluation of them and tell them in truth, as opposed to, if you sent me out to do that evaluation with my stepfather, I'm not exactly sure how honest I could be with him without, tweaking a few things so that I didn't tip him off to the fact that I was looking to make a change. I'm thinking that he could benefit from PT for balance training. A lot of folks, they don't want to hear that. They hear PT and they think to themselves, or even occupational therapy, they think, oh, great. Someone who's going to tell me what to do. So I need another person doing that. They're going to give me exercises, which are torturous. And they're going to come into my home and possibly tell me I can't live here anymore. That's unfortunately some misconceptions there, although we do like to give exercises. I'm not going to lie. But I think, for me, the goal was always to meet them where they were at and just be honest and tell them what I was seeing. And I think one of those things that helps you do that is an assessment, an assessment of that individual. And that could be, you're not just assessing the individual, you're assessing the entire living situation, from family dynamic to the structure of the place that they're living, the home that they're living in, and then, of course, to their capabilities or their deficits. So you can make the best recommendation that is at least palatable for them to be able to say, okay, I can buy in. That's a lot of what we're doing, is we're trying to get the buy-in and convince them, in a non-scary way, this would benefit you and accomplish the goal of staying home. That's usually the big goal. And I always started with that and finished with it when I would have a patient encounter. That way they actually knew that I had what they wanted at heart. Because that's really, at the crux of it, that's really what they want to do. And I said, how can we have you do that safely? The assessment is a great way for us to kind of identify those things.
So how have you used your experience as a physical therapist in your own caregiving conversations within your family? Like how, like you were saying, it's one thing if you're talking to your stepfather, but it's another thing if you're operating as a clinician. So how has that experience made you think differently about how you, prepare your own family members for this phase of life?
So I think the first thing is to recognize that everyone is an individual, and therefore every approach that you take has to be individualized. It can't be just a one size fits all. I can't just have my spiel that I go in and give to everyone the same. I have to understand that person. That's probably the most challenging thing for me, is getting to know them. Now with my family, of course, I have a leg up with that. Sometimes that's good. Sometimes it's bad. I find myself having to reset and say, okay, we're going to play through this as if you're not my Uncle Patrick, and I have to be able to kind of see this through new eyes, because you can lose things if you just see them as Uncle Patrick, right? So I think for me, that is a big thing that I keep in consideration. And I get these calls all the time, right? I think they all think that they had something to do with me going to PT school. So they feel like, oh, I'm going to call him and have him treat me over the phone. I said, okay, happy to help. But obviously for me, in person is probably my preferred method. Really lets me see the house, and it really lets me really see how they're moving around in that home. So I think as far as, how do I tailor that conversation? Again, I think it's true honesty. is the hardest thing when you're treating, which you really shouldn't treat family members. Formally it doesn't happen, but informally I can't help myself but make a recommendation. PTs are the worst at that. And find ourselves out in public and we see someone with the cane on the wrong side. And my wife and I, she's also a therapist, we look at each other, should we tell them? I said, no, you shouldn't tell them. What's wrong with us? Why do we do this? But I think for our perspective, you can't help but be honest about that. Yeah. And I think the other thing that is very helpful in convincing someone, family member or someone who's not a family member who might be a little skeptical, especially if this, the PT eval is generated or is kind of pushed by a family member, I speak to them in almost an educational fashion. I say, look, we're going to go through some standardized objective measures. And they go, what is that? Stop with the jargon. I said, these are just some tests that I'm going to actually run through with you to see what your capabilities are and to see really realistically in this aging adult population, not patient population, old habits die hard. I said in this group of folks, they appreciate the education as opposed to just being told what to do. The why is super important for them. And being able to have them understand that these tests are going to actually help me determine what their fall risk is, as opposed to just going in and saying, yeah, you look like you're a moderate fall risk. No, the numerical kind of values that I get from doing this in the scoring really lets me tell them, hey, you're at a low fall risk based upon your age and your gender, and I can tell the family member that sometimes as well, which is, I think it's really good. And I encourage the family to be involved. If they have been involved with, initiating an assessment, be there, be a part of it. And I think it's very eye-opening for them when I said, I did all the testing with mom. She's a low fall risk. And I could see mom over in the corner going like this, But that's the nice thing is everyone can be on the same page if you use something that's objective and really kind of lets them understand better how they're doing.
Yeah. Thank you.
Yeah.
So you mentioned a few times about sort of this goal of aging in your home, right? And we know that that's very important to a lot of people as they age, that they want to stay in their home. We know the outcomes are better when they can age in their home for as long as they can. With this increased risk of fall prevention, can you truly make your home a safe place? Like, can you do the exercises? Can you do the modifications? Like, can you eliminate? I know you can't completely eliminate the risk of a fall. That's not possible. But what are some of those high impact efforts that you can make preventatively to make sure that you can stay in your home as long as you can?
Sure. And obviously it depends upon the layout and the home itself, right? I think that has a lot to do with it. But I think, for me, structurally, I think the biggest place of initial focus and the one that's least obtrusive is changing the lighting and is in the bathroom. So many falls happen in the bathroom. It's wet. It's slippery. Sometimes if you don't have grab rails, there's nothing to hold on to. And you have someone who's already having a reduced amount of step height that they're walking with. Having that same person lift their leg up over a tub is putting them at increased risk. So I think, things such as grab bars, installed in the shower by the toilet to help someone get up and off, is certainly the low hanging fruit, as it were. Certainly a commode chair and shower seat, again, depending on what folks' needs are. But those are the ones that come to mind instantly, and they're not a big lift. And certainly the other thing if someone's on a fixed income, it's not a huge cost. And there's communities, a lot of times communities will have resources that people can tap into and makes it doable, because that's the goal. How can we help you age in place gracefully and safely? The safely part kind of ties into the gracefully, because if you're not safe, it's not going to be graceful. So I think those are the things. And on the outside, just shoring up those handrails if there are stairs to egress the home, obviously the other piece, this is both in the home and outside of the home. Do you have the right assistive device? The least restrictive. I don't, everyone goes in and tries to put a walker in front of somebody. You actually can do more harm than good doing that, because you're actually promoting that forward flexed posture that I talked about. It's also, if it's too clunky, they don't want to use it. And there's also, of course, a little vanity involved many times where they don't want to take that in public. So finding the least restrictive, that's going to get them the safest possible for where they're at that part of time. And then that may change, better or worse throughout time. But that's probably the other cost-effective thing that you can do that's most impactful right off the bat.
Do you see a difference between sort of the I guess, danger level of stairs versus ramps?
It's funny. People have this, unfortunately, they have this ill-conceived notion that ramps are safer because it's a gradual incline or decline, depending on which way you're going. But in the stairs, it actually typically makes people stop and do each individual stair individually. And hopefully there's a railing at least on one side, if not both. That's optimal. So I think that actually people are more deliberate on the stairs as well, where I've seen people on a ramp, if they're not actually using, if they're not using a walker, they'll actually build up a head of steam on the way down. So that can be, contributory to a fall as well. Look, I think it's like any other piece of equipment or, if you're traversing any type of terrain, it's, know what your capabilities are and try and do it in the safest way possible. So my preference would be to have someone use the stairs if they're able. The other reason is, again, a shameless plug here as a PT, it's functional strengthening, right? So many people avoid using the stairs when actually they can do it, and they can do it safely when there's a railing there. It's an unfortunate loss of functional strengthening for them to be able to maintain or at least slow down that progression of muscle weakening.
What are your other favorite exercises for that functional strengthening when it comes to fall prevention?
One of the simplest ones to do is a sit to stand from the chair. Either choose a time period, 30 seconds. How many times can I go from a seated position to a standing position in a controlled fashion in 30 seconds? Or, and some folks prefer rather to then do that, is to do 10. I'm going to do my 2 sets of 5, right? In quintessential PT speak, we have to give it to you in sets and reps. So that is, something that a lot of people will do. That's great strengthening. It's functional. That's the thing with this. I'd be remiss if not mentioning the best functional exercise that you can do is walking if you're able to do so. It really is one of those things that's low-hanging fruit. Most people like to do it. Some folks want to do it around the neighborhood. Some want to do it to the fridge and back. It depends upon who they are, right? I think, but I think the walking is something that for so many reasons, obviously the cardiovascular benefits, the strength benefits to some degree, but it's also a balance issue. If you don't use it, you lose it. And balance is very much that way. Most people think of, you can strengthen the muscles in your leg. Well, you can also fine tune your balance system. And unfortunately, because people, older adults will reduce the amount that they're walking, they stop challenging the outer levels of their balance. And so they actually are putting themselves at a greater risk for falls. So for me, walking is great. Now, sometimes people are limited in space, but if you can get somewhere where you can go walking that's flat terrain, great. I also encourage people, if it's safe, to be able to go on uneven terrain so you don't lose that. It really depends upon where that person is at. Getting to be able to see them move, to be able to make the right calls as far as how is to kind of guide them and what's beneficial. Sometimes you worry about that I asked them to do too much, now they're tired out and I put them at greater risk for fall. Again, that's why an assessment is necessary. That's why when Uncle Patrick asked me what exercises he can do over the phone from New Jersey, I'm like, sorry, you're going to have to wait until I come and see you. That's when I can't answer over the phone. But so.
What about shoe advice? Or when you're doing those exercises, do you recommend people do them barefoot with shoes on? And then sort of part 2 of that question, when they do have to wear shoes, any guidance on what's best for helping prevent falls?
Yeah, sure. And that's a question that some people, I don't want to say that they struggle with, but I think for me, I need to get a sense of who that person is first, right? If I ask someone to put sneakers on to do the exercises and they hate sneakers, they're not going to do the exercises. So, for me, as long as it's not a safety concern, I really can't ask someone to do heel and toe raises in 6-inch pumps. It just doesn't work. Okay. But for me, I think it's, a good solid shoe that is got a supportive back and is, and if they wear insoles, that they should be doing those with them in there. Sometimes what they have available for footwear will actually dictate what I ask them to do. Right. So realistically, it's just something that they're comfortable in, that they're going to wear. Usually it's the footwear that they wear on a normal basis, which is funny because some people are strictly no shoes in the house rule, right? So I kind of have to work with them and find the exercises that are right for them to be able to do with bare feet. Preferably not socks on the hardwood floor, which does happen. But I make my safety recommendations and I win the battles that I can.
That's what the throw rugs are for.
Yes, exactly. That's exactly. A little more padding, Oh boy. It's like you were in the house with me. Okay. And I think the biggest thing is if someone is going to do standing exercises and they have that as part of their program, which many do, most homes, if not all, have a counter or a sink. It's a great place for folks to be able to hold on to and it gives them that solid, it's that solid base that they need to support them. It's kind of like the older adult version of the ballet bar. Okay. Yeah. It's really, a great way for them to provide that stability and not have to purchase anything. So
is there a purpose for upper body strength when you talk about fall prevention, or is it mostly balance related where you're just really trying to keep your...
I think it's everything. I think, I'd be foolish to not, give a shout out to the OTs who would say, Brian, don't ignore the upper body. And I think from my perspective, it's really about, do they have the functional mobility up top? Have they, maintain that to be able to stay safe when they're getting dressed? Are they able to get things out? Do they have the strength to get items out of the drawer and bring them over, even if they're going to get dressed in a seated position at the edge of the bed? But did they have the capacity and the strength to bring the clothes over to do so? Do they have the ability to don and doff their shoes, put their shoes on and off? Sorry.
Very fancy.
Very technical. Yeah, sorry. It just rolls off the tongue, don and doff. So I think that is, for all other reasons, any other reasons, but that's really one of the big ones. It's a function-based part of this because if they're weak up top, they're probably going to start doing funky things and put themselves at risk for a possible fall or taking a chance.
Yeah. So what I'm hearing is that, falls are a very pervasive issue for older adults and can often sort of be the beginning of the end when they happen. So in keeping them from happening is very important. The signs that a fall is coming can be fairly obvious to those that are watching.
Yep.
Yeah.
100%.
And there are a lot of tools at our disposal, both preventative and home modification and just exercise related, to keep ourselves as safe as we can for as long as we can in our homes.
100%. And you mentioned one thing where, it's obvious. Sometimes it's subtle too, right? But it's enough where you say something's not right. I'm not sure what it is. You see something, say something. There's no harm and foul in bringing someone in to be evaluated or having someone go out to their home to be evaluated. And you get a better sense. And so for me, there's a lot that can be done. It's just amazing to me that in 20 plus years, I'll just leave it at that, 20 plus years in this space, that we haven't come, a longer way. In fact, that divide, the numbers are indicating that more falls are happening now. I happen to think that some of that is they're being reported more often or witnessed for a long time. I could tell that someone was falling when I would go to their home. Obvious bruising that would indicate a fall, but they're not going to tell you because then you're going to get extracted from their home. There's a big fear of that. And I think if we can squash that a little bit and say, hey, let's get you safe or keep you safe to keep you in your home, as long as you're leading with that, if that's what they should so desire. Some folks don't want to do that. They want to move to a community. They want to move in with, a relative. Again, meeting them where they're at is the key.
It seems like a common theme for these conversations is how important it is to have a very honest and open dialogue with either yourself or your loved ones as they age about the challenges that they're coming up against and how everyone in the family unit can sort of best prepare so that you can stay as safe as you can, as long as you can in your home. So I want to thank you, Brian, for joining us today and sharing your expertise and guidance.
Thank you for having me. I appreciate it.
Yes. With a lot of very actionable information for our audience and helping either themselves or their loved ones navigate fall prevention in this time of life. So I want to thank everybody for joining us for the There for Care podcast. Please like and subscribe, and we'll see you next time.